I appreciate everybody being here this morning, and I loved that Dr. Paulson asked about PACEUs, because until 2 years ago I had no idea they even existed. So this is going to be a story about how we've become involved with reproductive health in the environment and some of the science, although when I looked at the program today, I took a photograph of it so that I can use that in my lectures to show people that these kind of programs exist out here, because you guys are just getting everything started. And thank you very much, Dr. Paulson, for putting it together, and everybody here for participating. I have no conflicts of interest to declare. My goals really are to talk about some examples of environmental exposure and explain some of the relationships between reproductive health and the environment, discuss some of the testing, although the expert I saw, we've got Patrice Sutton, is going to talk about navigating the science. And if you can go back and help people understand how difficult it is to do the research and how important it is to look at this with a different set of glasses. I always say we wear different sets of glasses for different things. When you do research in environmental science, it's a different set of glasses than what we're used to wearing as obstetricians and gynecologists. And then my other plug is for some of the research that Dr. Howard Taylor is doing from Yale on DES and BPA. And I suggested if you ever wanted to get an unbelievable speaker to really look at some of the science there, he's a great resource and he's right in your backyard. This morning I'm going to talk a little bit about preconception health, interconception care, and what I call the environment of care. And this is very much like a cross between Romancing the Stone and The Accidental Tourist in how we became involved with this topic. Because there was no plan to say, okay, this is a really huge issue for us as OBGYNs, we've got to tackle it. It came about through preconception health care. I've been involved with preconception health since 1998, when Healthy People 2000 said 80% of every physician, not OBGYNs, every physician in the United States will know about preconception health. So California did a big push, sent information out to every doc, did panel studies and everything, and then queried everybody a year later and says, does anybody know anything about preconception health? Found zero. No one really had read any of the books, any of the information, any of the handouts. We realized that's not the way to get things across to people. So we developed a council to really emphasize how to integrate preconception health into it. And we're fortunate enough to host the second International Symposium on Preconception Healthcare. And we reviewed the risks of diabetes and hypertension. But Hania Trosh from the CDC called us and said, you've got to talk with UC San Francisco. Well, the conference was in Oakland. We thought, well, UC San Francisco, they're right across the bridge. We can do that. And that's when we found out about the whole program on reproductive health and the environment that was taking place at UC San Francisco. Dr. Trosh said, get hold of Tracy Woodward. She needs to give a talk for you. And it opened our eyes. So some things happen accidentally. There was not a person on the program who really knew that we should be talking about this when we're discussing preconception health. And this was only, I think, 2006, 2007, so just a few years ago. It was not long ago. Well, then the most important moment came when then we were suddenly the experts. And in California, we've got a very active legislative program. And I got a phone call from the legislator saying, what stance is ACOG going to take on lead in lipstick? And I said, shoot, we didn't know there was lead in lipstick. We have no stand. What should we do? We had no idea what to do. And they were coming to us as the expert. So this is my plea to you to realize that you are the experts. You're going to be considered the experts because of your field. And if you don't know, find it out. And we became much more closely involved with UC San Francisco. So my other plea to you is just say yes. We're going to have a number of times when you're going to be asked to be an expert, to take a position, to become the champion, maybe in your department, maybe in your practice group, the champion about an issue. But when it comes to reproductive health and the environment, say yes, learn more. We know that it is only if we help women become healthy in their lives. And you'll hear me over the course of this year with my bully pulpit talk about well women health care. Because I firmly believe the only way we're going to see some changes in the United States when we look at maternal health outcomes is if we focus on well women health care. We help women become healthier, eat healthier, exercise better, control diabetes, all of those kinds of things before they become pregnant. And we all know that 50% of pregnancies are surprises. So it gets back to, you can't wait until somebody comes in your room and says, I want to plan a pregnancy. We've missed 50% of the population. So we have to be the experts who are going out there, because healthy moms hopefully get us healthy babies, and that's what our goal is. So 50% of pregnancies are unplanned. 80% of women are going to conceive at some time in their life. So we've got those years, those reproductive years, you know, from 15 to 45, 13 to 50, whatever we want to look at, those reproductive years. We used to say 18 to 40, but you know, we're spreading that out. And 70% of women are going to conceive a second time. So whatever we learn from a pregnancy can impact a future pregnancy. Now, one of my mantras that you'll hear about is every woman, every time. That means every contact a woman has with our medical system, every single time, we need to focus on well women health care. And whether that is diabetes, exercise, healthy choices, folic acid, all of those things need to be our mantra. Every woman, every time. And we have to be the ones who say that. And we need to take that to our colleagues. One of the other things that I've got with my bully pulpit this year, one of the past presidents said, use it because you've got 1 year that you can talk about a lot of different things. It's the well women visit. So we really pull together experts from across the United States, representative from each of the medical groups that will be seeing women while well women health visits are covered. So internists, family physicians, physician's assistants, nurse practitioners, nurse midwives, and OBGYNs. And we've got everybody in a room to talk about what's the lowest common denominator. If everybody's going to have a well woman visit, and you're an internist seeing a 33-year-old woman with diabetes, I sure don't want you to talk about a hemoglobin A1C that's 8 with her. We need to be looking at things very differently with women of reproductive age. And that's got to be a very consistent message across anybody who's doing the well women care. The best thing about the Affordable Care Act is that it is women's health care. And it is an investment in this generation for future generations. So it's an absolutely exciting time for all of us as OBGYNs because of those changes. My bully pulpit this morning, though, is the environment. And I think that we all know about the environment, we just don't realize that we do. We all know that there are times when we're talking about nutrition, food, dietary changes. We're experts on hemoglobin A1Cs and the impact of that on the fetus. We know about lifestyle choices and substance abuse. What we need to do is look at the big picture and realize that that environment includes industrial chemicals, agricultural chemicals. We can talk about physical agents and byproducts of combustion. We've got this whole host of things. So a lot of times we've said that's the environment. We need to realize that we've got this whole thing that's an environment of care that potentially is impacting moms and fetuses, that husband, that's partner also. So I came up with a list of things, what I came up with, why don't we talk about environmental issues? And we were brainstorming, a whole group of us saying, you know, what is it? Well, some people are going to say that the research is absolutely lacking, so we can't talk about it. There are others that I think are just not comfortable with the topic. And your example about patients coming in with their Google list and questions for us is true. There are no data to address this, so historically we just don't want to go there. We've got more important topics to discuss. And there was actually a very good article in the Green Journal that said, you know, if we're asking women, we're asking about their diet, we're asking about knowledge of diabetes, how often do we ask our patients about their knowledge about what they're being exposed to? My favorite is the ostrich approach. I saw this when we were doing domestic violence screening and depression screening. We put our head in the sand until we had a response. It's much easier to not ask about domestic violence if you don't have a response for that patient. And I think this is the same thing. If you don't know what to tell a patient, you just kind of don't even ask. It's easier to live here than to look out here. Some people just aren't aware that there's a problem, and programs like this will certainly help. And the other is we really do. We just haven't explained environment large enough. We talk about the environment with diabetes, blood sugar, we're very comfortable there. So how come we cannot look at all of these as different aspects of the environment? And then I thought, well, how do we get the attention of all clinicians? Well, first off, if we go back to some of what we've learned about preconception health care, a lot of this isn't even on our radar. We think we're doing a great job with preconception health care, but if we're not addressing a lot of different things at every well woman visit, we've missed 50% of the time when we can talk preconception health. If we learn from our colleagues in internal medicine, where they've regulated, they've run chronic conditions management programs, they do specific outreach along certain goals because they want to optimize health for certain people. We can learn from those kind of programs and say we can do things better, but we've got to use more of a systems approach. So again, it gets back to the theme that this is all about well women healthcare, but we've got to take well women healthcare and reproductive choice and always keep our eyes open when we come with reproductive choice. The other thing I do is get attention, so we have to be able to translate some of the science. And the science gets a little difficult. Now my eye-opener was getting exposed to that little mouse down there, because in the world of research, that little mouse is really critical because there's a lot of research being done on that. But then the others are all photographs of animals that are taken out of the environment. A lot of it from Florida, unfortunately, and a lot of pesticide exposures. But these are real animals that are being exposed to some type of toxins in the system. If we ask ourselves, what is the backdrop here? I call it the backdrop of diseases that we see. And whether we're talking about rates of testicular cancer or breast cancer, we can look at hypospadias or decreasing sperm count. The backdrop to the discussion is that we see a number of disease processes that have increased in a fairly short time period. And as Dr. Paulson pointed out, we don't have the absolute links to say this was caused by that. We have a backdrop that says we've got this host of patterns that we're seeing. At the same time, we're seeing environmental exposures. So why have some disease processes increased over the last 40 years? Genes haven't changed over that time. I'm trained in evolutionary biology. My PhD was in ecology and evolution. When you look at evolutionary biology, there's this discussion about saltatory evolution, and that evolution perhaps takes place in leaps and bounds. But the leaps and bounds that we look at in the records are more in the thousands of years and 10,000 years, not 40 years. So when we're talking about evolutionary processes, it's usually not something that we're seeing in about the last 30 to 40 years, like some of this backdrop I talked about. And we're not really going to understand some of these disease processes without really understanding the environment. And you said it so eloquently. There are risk time periods in anybody's life, a high-risk time period. And whether we're talking about a fetus or other stages, that's the other backdrop that we all appreciate. And I think as OBGYNs and pediatricians, we understand that better than almost anybody. Should we be concerned? We can look again, that backdrop. Diabetes increasing, autism increasing, asthma increasing, ADHD. We haven't the foggiest idea truly what's that backdrop, what's causing it, but we do know things are changing. The third thing is, I would say we've forgotten history. So I've got to do a quick quiz. How many in this room know about DES? Thank you. Okay. This is so I'll give you my other disclaimer. The good thing about being an OBGYN involved in this is that we get asked to give talks to the straight PhD people who are doing the studies on the little mice, and they don't talk with clinicians. So when I was giving a talk to NIEHS last year, National Institute for Environmental Health Sciences, the PhDs there said, oh, nobody even knows DES. I thought, oh, that's our bread and butter. You know, we know DES. We've got that. And they said, no, nobody knows that any longer. If you talk with the medical students and the residents, they've never heard of it. So now I ask my audience, do we know DES? Because I don't think we've forgotten history, but we consider it history is our problem. We look at DES and said, gosh, we learned everything, 50 years ago. That's not happening now. But when you look back at methyl mercury, how many years it took us to understand mercury impact? It was a long time. It was 20, 30, 40 years. And we've got the endocrine disruptors that are here in the 21st century. So we need to learn from history. CDC has a great website on DES. If you want information, we've got it there. We've got the ads from DES from the 1950s. Those were the commercials that were telling women they should be there. The reason we need to be the clinician having these discussions is at that very same NIEHS meeting, there were a couple people who said we're doing exactly the same thing now because we've told women to take progesterone during pregnancy. And I about had heart failure because I know when I've got a 28-week woman who's had one pregnancy loss, and she's on progesterone and I've saved that baby's life, I've made a difference. But we've got to be the clinician that says, you're right, there are risks and benefits to everything we do. If you find a risk to progesterone, I've found the right reason to be using that, and it's really important for us. So each of us is bringing our clinical expertise, and it's really important for us to be that voice out there because there is not another voice. But if we look, we understand DES, and now we actually understand exactly where some of the impact and the exposure to DES, where it was having an impact on the fetus. I had some fun times taking out pictures and showing where the impact was. But if you think about DES, it was the lower part of the reproductive tract, the lower part of the vagina, the lower part of the cervix and upper part of the vagina, where there's an actual transformation in the genetic material there. We now know that down to the molecular level. We've actually seen that there is probably some transgenerational impact, that when they followed some of the DES families and the offspring of the DES families, they found some of the same changes in those offspring. They have not figured out how that transgenerational impact is happening, but it appears that it's there. If we look at mercury, we understand that mercury is an exposure that we get from the environment. In California, we've actually have the lakes plotted out in the Sierras to show mercury content in some of the different lakes. So if you went fishing and you were going to eat from it, eat the fish that you caught, you can actually come up with a level in the different lakes and know what your exposure is. But look at how many years, from Minamoto, Japan, how many years. This photograph I remember from the 1970s. I remember when Audubon magazine actually published this photograph. It took us 20, 30 years to understand the impact of that. We're looking at neurotoxicity. Pediatricians understand this much better than the rest of us, what the impact is of mercury exposure on the fetus. We've seen mental retardation, ataxia, seizures, vision loss, hearing loss, cerebral palsy, deficits that are a tremendous impact on life. And now we're actually seeing that there may be some transgenerational impacts. So not just the first generation, but the second generation. How? We haven't figured out the how, but we're seeing those patterns. But then let's step back and look at chemical exposures. There are 84,000 different chemicals that are listed by the EPA, 700 new chemicals every year, 3,000 are high volume. The burden of proof with any of these chemicals lies on you and me, it lies on the consumers, it does not lie with the chemical industry. And what Patrice will talk about very eloquently later on is we need a different set of glasses when we're looking at the research, because we cannot do the randomized controlled studies that we hold so dear to our hearts. We're used to when a pharmaceutical that we're going to prescribe is put on the market, we know it's gone through those mice studies. It's gone through some human studies, and we're finally using it. That's not what's happened. The chemicals are being released, and then, oh, by the way, we study them. And that's not the way we need to have it done. But it does limit our being able to understand the impacts of chemicals on health. In fact, if you look at the blood of pregnant women, I think we figured 43 different types of chemicals in the bloodstream of pregnant women. And that's BPA, you name it, a whole host of different things. And I said our 21st century view is going to be looking at endocrine disruptors. These are chemicals that are going to mimic our own body's behavior and interfere with the balance in our bodies. And those endocrine disruptors can be found in any number of things. I've been giving interviews about this topic the last couple of days, and the easiest thing to say is our tomato cans. You know, I make pasta and I make my tomato sauce. My tomato cans have a lining with BPA in it. How many of you, you're all very rushed with your lives, with your practices. You just want to eat a quick breakfast or quick dinner. You just throw everything in the microwave in whatever little plastic container we've got. We're talking about BPA risk. So there's all of these endocrine disruptors that are out there in our environment every single day. We know that there have been associations between them and different forms of cancer, breast development, prostate cancer, some of the research that's coming out of China looking at changes in sperm count. So we're seeing associations between endocrine disruptors and some of the disease processes, whether those disease processes are in the Lab Animal Association, we're seeing those processes happen. So again, I say get back to that little backdrop of disease processes, and at the same time we look at the exposure to different chemicals. Then if you take the work of Dr. Taylor, where he's actually looked at BPA, he's looked at the genetic, and he's looking at the cell layer and what's being affected, he can identify exactly what genes are being affected by BPA. And if you look at where it is compared to DES, it's the same genetic material, but just a different part of the reproductive tract. The reproductive tract for DES is at the lower aspect of it, the lower part of the cervix and the upper part of the vagina. BPA has its selective effect on the upper part of the uterus, the tubes and the ovaries. But it's the same genetic material that's being impacted. If we look at some of the synthetic chemicals that are out there, PCBs, I said that this is just a whole, we've got the alphabet soup of things out here, the BPAs, the DDTs, the DES. You know, I'm a Silent Spring child. I remember, when those books, Rachel Carson's books came out, and now we're revisiting that. We never really got past some of this, but we have to look at some of those exposures to our patients. If you look at pregnant women, every pregnant woman, when we've tested at least 43 toxic exogenous chemicals in their body, we're seeing measurable levels of BPA, toluene, mercury, and lead. And we've all seen studies that have documented that they have a potential impact on health. The areas that we have to be cautious about is we have to say we have potential impacts. We don't have double-blinded case control studies, but we're looking at overwhelming types of research and being able to take what we call translating the research from one location to the other. I won't cover this in much detail, but it shows you the difference between, on one side, how we in the clinical world look at a new pharmaceutical design and all the different types of testing, and then it's being released to the environment, released to us using it in the environment of care that we provide, versus the environment where we're releasing chemicals in great numbers, not doing any studies, and then if somebody says, I've got a concern about it, that somebody has to do the study. It's not going to be anybody else doing it. And that's where our voices need to be heard. So how do we interpret the research? We put together a navigation guide with scientists and clinicians who can look at the research and provide experience and provide examples. If I translate this as a clinician, though, what I need is an app. Give me my app, and I can put it down. We've got, the environmental equivalent of drugs in pregnancy and lactation. I flip through that book all the time. I use that information. The exciting thing is, I'm at ACOG for the next 3 days. We were having our government relations discussion yesterday, and Dr. Lawrence, our executive vice president, said they're working on an app for this information, not for toxicants, but for drugs in pregnancy and lactation. I looked at it and I said, I've got a chapter for you. I've got an app, part of the app. We've got to get this into any app that we talk about. It's got to be there to help each one of us. Otherwise, if it's not easy for us to get to, we don't spend the time on it. So what would I like? I would love us as physicians to be able to address this. I'd like us to be able to, when a patient comes in, to have us feel more comfortable with this topic because it is a very difficult topic. We want to be able to give some sound advice. And I'll tell you, we're getting a lot of phone calls saying, what advice should I give? What should a clinician be able to say to their patients? And I look at this in terms of pennies and gold. We always look at things in terms of the gold standard. And that gold standard is the double-blinded case-controlled study. If we don't have the gold standard, and if that's the only thing that we're going to hold out for research, we get pennies in the advice that we give. So you have to be able to look and say, we are going to have to translate our understanding of the type of research in a completely different way, and it gets us out of our comfort zone. So we've got to rely on experts who can help us understand that, people who have a much greater understanding of environmental issues and the environmental science. One of the things that I try to use is a precautionary principle, and that says that when we're looking at the burden of proof, if there is a suggestion or a concern that that chemical may produce some harm, we want to be cautious in our recommendations. And I'll give you an example that's happening right now. We were talking about it earlier. Dr. Emily Oster is a PhD economist at the University of Chicago who is now the world's expert on drugs and alcohol and pregnancy. And she says that every woman should be able to drink alcohol, a drink a day throughout pregnancy, and has her mommy bloggers going wild, and everybody. She doesn't believe in the precautionary principle. She believes in the randomized controlled study, and if you don't have that gold standard, everything's fine. Well, I don't think everything's necessarily fine, but I don't want to be alarmist. And that's where we have to be really cautious. We have to be able to say to people that we're concerned, we're aware, and it's how do you bridge awareness with alarm? And that is going to be a very tricky message for all of us. How can we lead? Line one, we get to check off. So you guys are on the inner scoop for this, because on Monday our committee opinion is actually, Monday our committee opinion is being released. We've got it embargoed right now, but we've had a lot of phone calls because the embargo will be lifted on Monday. It's being published in the Green Journal, and a number of all the publications out there. We've got USA Today, a number of different news centers have the information that we're going to be talking about this as an ACOG committee opinion, providing guidelines to our physicians. The number one, actually the two questions that we're being asked is, what can we say to patients? And our message to patients is actually going to be pretty straightforward and pretty simplistic. Do the things that we already say. Wash your vegetables, eat healthy, make sure you're rinsing things, limit your exposures. Cook in glass, not plastic. So we've got some things, and we've got great resources to link them to. But how can we lead? By ACOG coming up with a committee opinion to provide some guidance to our physicians and for us to guide patients. ACOG and ASRM have a joint opinion. We weren't able to get SMFM in simply because of the timing for the committee opinion, but they've been part of these since the original discussions 3 years ago that we wanted to pursue this area. Get state and national legislation on environmental issues. Now, one of the concerns is this is going to happen piecemeal, and it's not going to be, it'll be difficult. And I bet that happens. I mean, we see piecemeal legislation in California all the time. We had a piecemeal with flame retardants. We have a piecemeal on BPA. That's going to happen. Trying to get large-scale environmental legislation through Congress is really, really difficult, and I'd hate to say that I'm optimistic on that one. We can dream. But we want to have educational opportunities through our clinical meetings, through our district meetings, ABOG, having them have some questions on the exams, and at CREOG, being able to talk with CREOG about this. What I tell everybody is, the thing that I would love you most is to take this talk, take my name off of it, put your name out, and give the talk. Because I love having everybody be able to feel comfortable that you can give a lecture and become the experts. And believe me, I can tell you my history. It really does go back to lead and lipstick and not much further back than that. As clinicians, we can take perform an occupational intake on our patients. It does not have to be huge and detailed. We can ask a couple significant questions in terms of home life and work life, and that is a good screening tool. So it doesn't have to be a 2-page documentary. You can make it very brief. We can provide guidance to our patients and just let them know what your concerns are. How many have electronic records? Do you guys use Epic? No. Yes, there was a yes. Okay, so I use Epic. The after-visit summary. My after-visit summary now has information at the bottom of it that I just give to everybody. I refer them to the UC San Francisco location. I give them a couple different examples. I put that, it's just in all my summaries for every patient interaction. Then I don't have to think about all of it. I just say, here are a lot of things that we've talked about in this visit about choices you can make. These are a number of sources for you. We want to make information easily available for our patients. We want to make it so that we get our head out of the sand and aren't ostriches, and we feel comfortable providing a couple tips for our patients and not making it a horrendous deal. If it's a horrendous deal, then it doesn't happen, and that's where we get intimidated. And then the other thing is, once ACOG has a committee opinion, we can now take a stand nationally in terms of legislation. But until ACOG has a really firm opinion on things, we sit back a lot of the time and aren't able to take a stand. And it sounds like that's a tiny issue, but it really is a very important issue for us. There are times when there are issues nationwide. I can give you examples on abortion or midwives and things like that, that if we haven't taken a true committee opinion with ACOG, then we really can't not take a stand. So this for us is very important at the national level, because as I said before, one of the concerns is the burden of proof is on all of us. And what we need to do is shift that burden away from us and have it before the chemicals are actually released into the environment. That's got to be one of the goals, and that's the only way we'll actually be able to help patients. Resources. One of the things that I was asked yesterday is, what do I use for a resource? You know, do we have to hire a lot more geneticists? We don't have enough geneticists out there. We said, nope, we've got PACEs that are there. People need to know about it. In fact, we thought of renaming them PRACEs so we could throw reproductive health in there, pediatric and reproductive health. So we've talked about that. We actually will now have our own Bible. If you look at it, 2 years ago at that same meeting, I was introduced to the Green Bible. Pediatricians have produced their Green Bible that gives them all sorts of information about environmental exposures, and they wrote a chapter for OBGYNs because we hadn't done it. So they've had their Green Bible for what, 30 years? Or you guys have been working on this?
That long.
Yeah. Committee's been there for 30 years, but have been working on environmental issues for 30 years, and certainly have had the Green Bible for some length of time, and they wrote the chapter for us in there. So letting them expand, or at least now we've got a committee opinion that can help inform that. And then we need to collaborate with our colleagues so that any green agendas, anything that helps make our environment safer is something that we can do, and be the experts for medical organizations. So if we go back to that initial slide that I asked you about, when I said the research is lacking, we've got research there. We're not comfortable with the topic, I agree, so start educating, and everybody take this slideshow, put your name on it, you can delete mine, put your name there, and be the expert. There are no data. Give the examples of DES and what we've learned from DES and BPA. We have more important topics to discuss? Yep, we do. We've got a lot of it. If I could get somebody's hemoglobin A1C under control before they ever get pregnant, that would be a huge issue. If I could cure obesity and really get women's weight under control, that would be huge. We've got lots of topics. It doesn't mean you can't figure out some way to address this. Ostrich approach, I think, is human nature. So we've got to figure out what the resources are before we start addressing the question. And we're unaware of the problem. Now you are. So now you get to help everybody. We share a common goal, and we all have to appreciate that that goal is out there. No matter who it is, we do have a common goal across the United States, across the world. We want healthy mothers. We want healthy infants. If there was no doubt about the research, if there was no cost factor here, if all of those things were easily done, we'd be there. But that's not it. There are all these hurdles that we have to overcome. So we've got to agree that it's very important that we're starting here, that we've got to educate, and we've got to take a stand. And that's the only way we're going to see change come about. So it gets back to what I've called my mantra for the year, and hopefully not just for the year, but forever. Every woman, every time. Each one of us has to address every woman when we have our contact with her, and get other clinicians when they have contact with a woman every single time. Talk about reproductive health choices, and that huge environment of care that really I call the Well Woman Visit. Thank you. Any questions? Suddenly you will be the experts, because I swear the committee opinion is coming out on Monday, and we've had a number of phone calls. So if you are asked and say, do you have any comments? Contact us. We can give you some talking points, but say yes. Be willing to step up and talk about concerns about this, because each one of us has to be willing to be an expert for all of this.
One of the comments that I'd make, particularly in terms of folks who work in hospitals, I happen to work in a freestanding children's hospital, so we don't have any adults in our place. But in our place, and I know at GW, which is the adult hospital in the George Washington University system, a lot of hospitals are also doing work on sustainability. Interestingly enough, you all certainly have much more experience than I as a primary care pediatrician. So there may be mechanisms at that level or activities at that level that you can look to get some support for the work that you might want to do in your own department, with your own patients, in your own ambulatory settings, and things along those lines. So that may be a ready resource very much, you know, in your own backyard. So you might want to think about looking at that when you get back home.
That's a great observation. I know McGee Women and Children's Center has a huge environmental group, and it started exactly that way, with somebody noticing all the waste in the operating room, and then it's expanded to the entire campus. So a number of different facilities and hospital systems have that in place. It's a great observation. Well, one of the things, oh yeah, Bob?
Well, just to follow on what Jerry mentioned, there's major cross-hospital collaboration, such as the Healthier Hospital Initiative, which subsumes that type of work, which has signed up hundreds of hospitals looking to get many more. Kaiser, for example, with its program with environmental stewardship, has been a key player in that. And that translates to reducing, in many ways, the ecological footprint that our patients are exposed to in terms of the energy choices we make, the types of materials, chemicals we use in the hospital, food in the hospitals. Our own sustainability committee at UCSF, with Dr. Tom Newman, who's in the pediatric department. One of our first actions was to remove antibiotics in the meat and livestock, meat and poultry that we have in the hospital. As one example of those types of steps that can be taken on any of those plants that can have very significant health impacts.
Good observation. Hi.
Thank you for a great talk. Is ACOG making any statements or releasing anything in their committee opinion on up-and-coming opportunities to reduce pesticide exposures, such as GMOs?
No. I mean, it's looking at the research that exists right now. It's a very broad type of committee opinion. So what it's doing is looking at some of the research that's led up to this point more than anything, and then providing that type of guidance, saying we need to be there at the table when anybody's talking about pesticide exposures and things like that. Yes.
Within ACOG, you have your senior population and junior population. I suggest that the junior fellows are at a point in their lives where many are casting about for causes on which they could make a difference. Not just a little dabbling difference like a 5-day trip to Guatemala for surgical relief, but something at which they could be engaged in the community, hospital, state, and to the extent you can reach them and get them moving through the chain of command committee structure that you have, that might have an effect.
Yeah.
Then also at the executive level, your contacts with the National Organization of Midwives, the collaboration work, and the family practice folks to get to these other trade guilds and say, follow me, here's our list of principles, get on with it.
Yeah. I'm hoping that, I'm a Pollyanna in a lot of ways, so I'm really hoping that with this committee opinion coming out, that can really be the stepping stone to a lot more. And that's a great idea, being able to just say, look, we're willing to start with all of your annual meetings and your local meetings. And certainly Meadow Good, who's the junior fellow chair, has been involved with some of this. So this is the time to touch back and reach with her. That's a good observation. Yeah, so if anybody here wants this is your passion. And like I said, I really do believe in leadership, just saying that you want to say yes and find what your passion is, and being able to embrace that, because there are going to be others who need your assistance. So being part of ACOG, to me, I've been there since I was a junior fellow, and it's been one of the most rewarding experiences of my life. We speak for the physicians across the United States, and the thing that I'm most proud about ACOG is we are the voice of women's health. So we put women first. We look and say what is going to be the best for women's health care, and really if all of us can try and really achieve that, we've accomplished great things. When we go, we're here, you guys live in Washington, so you understand the Capitol being right here, but when we get a chance to testify, ACOG carries a lot of weight because they look at us as being a very strong voice for women, and it's very nice to be received like that because of that voice. So thank you for all that you do. I do have to escape. I don't get to stay the whole day because at this moment, starting about 9:30, we're talking about reproductive health and the environment at our state-led roundtable. Every year, ACOG sponsors one day for our government relations team that came in yesterday, and we talk about all the national legislation. And then the next 2 days are our state-led roundtable. So we take the representative, the chair of every legislative team for ACOG across the United States. So it literally is a huge table, and their lobbyists. So usually about 35 to 40 states manage to send somebody, and we talk about, I don't want to call it impending doom, but it's impending legislation. We learn from one state. So, you know, the breast density bills that started in Connecticut and have swept across the nation, there's some element of damage control. You know, what can you learn from what passed in one state and what it's going to, you know, what other state looks like it's going to happen? What are the words that we can get out there to change it? So we've got that, and we learn from one another on any number of different legislation. You know, I was in Missouri 2 days ago, and we were talking about all the crazy laws that Missouri has passed. So having our states get out there and be aware of what's happening is important. And they picked reproductive health and the environment as one of their major topics that will be discussed this morning. So thank you so much for being here.